definition of drug-induced liver injury is one of the following. 1. AST or ALT more than 5 times the upper limit of normal, or the ALP more than 2 times the upper limit of normal on 2 separate occasions 24 hours apart. Number 2, total bilirubin more than 2.5 milligrams percent, along with an elevation in AST, ALT, or ALP. Number 3, INR more than 1.5 with an elevation of AST or ALT or ALP. The mechanistic classification of DILI is direct, indirect, and idiosyncratic. The direct one, the incidence is common compared to the other two. Idiosyncratic is rather rare. Dose-related would be direct, partially in indirect, and idiosyncratic is not dose-related. The latency, it happens within days in direct. It's very rapid onset. Indirect is delayed. It happens after months of exposure. Idiosyncratic is variable. It can happen anytime. Liver injury, in direct, there is elevation of AST or ALT or ALP plus or minus hepatic necrosis. Indirect injury is usually immune-mediated hepatitis. The patient can have a fatty liver, can go on to have a chronic hepatitis. Idiosyncratic is mixed or cholestatic picture. There could be a bland cholestasis and there could be chronic hepatitis. Examples for direct are acetaminophen, niacin, IV methotrexate. Indirect are protein kinase inhibitors, immune checkpoint inhibitors, anti-CD20 antibody. Idiosyncratic reactions are in augmentin, cephalosporins, nitrofurantoin, INH. If DILI is suspected, we have to suspect it if there is liver injury within 6 months of onset of drug exposure. We first rule out viral infections like hepatitis A, E, B, and C. If increased AST to ALT ratio, we even have to rule out alcohol intake in the history. If the aminotransferases are high, rule out autoimmune hepatitis as well to an ANA-IF and asthma. If the serum alkaline phosphatase is high, we rule out PBC by doing an AMA plus or minus do an ultrasound MRCP. After stopping the drug, you should see an improvement in most cases, and that is important in the diagnosis of DILI. So the stepwise approach would be first determine the R ratio, which is ALT by upper limit of normal divided by ALP divided by the upper limit of normal. If this R is more than or equal to 5, it's a hepatocellular toxicity. If the R is 2 to 5, it is mixed. If the R is less than or equal to 2, it's cholestatic. Then, if it is cholestatic, we do an ultrasound, we do an EUS, MRCP, AMA. If it is hepatocellular or mixed, the workup is the same. We look at viral infections, not only A to E, but we also look at EBV, we look at CMV, HSV, PCR. We do an echocardiogram to look at cardiac function. We do an ANA, asthma, IgG, and a liver biopsy for autoimmune hepatitis. Toxicology screen, drug and toxins in the urine. Ceruloplasmin level, ALP to total bilirubin ratio of more than 2, AST to ALT more than 2.2 is seen in Wilson's. Increased TSAT of more than 45% with an elevation in ferritin in hemochromatosis. Alpha-1 antitrypsin level and alpha-1 antitrypsin deficiency. Anti-TTG IgA level in suspected celiac disease. There is also another classification which is a clinico-pathological classification of DILI. First is hepatic adaptation. There are no symptoms. There's simply an elevation in GGT, serum alkaline phosphatase, or the total bilirubin. It's caused by drugs like phenytoin, warfarin, rifampicin, alcohol, carbon tetrachloride. This is due to the induction of cytochrome P450. Now, the difference between this and a cholestasis is serum bile acids do not increase in this, unlike in cholestasis, in which serum bile acids increase. 2. Dose-dependent hepatotoxicity. There is a rapid onset of symptoms. There is zonal, massive, and bridging necrosis, and the ALT is usually more than 5 times the upper limit of normal. It's caused by drugs like acetaminophen, nicotinic acid, and amodiaquine. Number 3 is acute steatosis. Microvesicular steatosis, severe lung injury. Features of mitochondrial toxicity would be lactic acidosis, pancreatitis, acute kidney injury, hypotension, and death. It's caused by valproate, diadenosine, heart, which is the commonest cause, herbal medicines, NSAIDs like diclofenac, vitamin A. Aspirin is the typical one that causes Reye's syndrome. Tetracycline in pregnancy, which is given IV, can also cause this. Acute hepatitis. The onset is 1 to 20 weeks. It's in 1 to 20 weeks. It has the patient has symptoms of hepatitis. The ALT is more than 5 times the upper limit of normal. There may be extra hepatic features of drug allergy like eosinophils and a rash. It's caused by INH, phenytoin, halothane, nitrofurantoin, disulfiram, ketoconazole, terbinafine, and sulfonamides. Chronic hepatitis. It's of more than 3 months duration, and the onset is after 3 months. There's interphase hepatitis, bridging necrosis, and cirrhosis. Some cases have autoantibodies. 80% of these people are women. They present with fever, arthralgias, increased gamma globulin, increased ANA in 70 to 80%, increased asthma antibodies in 70 to 80%. This is caused by nitrofurantoin, minocycline, etretinate, diclofenac, mesalamine. Chronic granulomatous hepatitis. You find hepatic granulomas. You have varying hepatitis and cholestasis with an increased ALT, increased serum alkaline phosphatase, increased GGT. The patient would have fever, myalgias, hepatosplenomegaly. The GGT is much more elevated compared to the ALT. It's caused by allopurinol, nitrofurantoin, halothane, hydralazine, carbamazepine, quinidine, amiodarone, and calcium channel blockers. Steatohepatitis. It's delayed onset of action from 6 to 18 months. There is a steatosis and a focal necrosis. Chronic liver disease can be present along with portal hypertension. It resembles alcoholic hepatitis and MASH. It's caused by amiodarone, tamoxifen, nifedipine and diltiazem, methotrexate. Bland cholestasis, in which there is cholestasis without any inflammation. The serum alkaline phosphatase is more than 2 times the upper limit of normal. They only present with itching. This is caused by OCPs, androgens, and cyclosporin A. Cholestatic hepatitis, there is cholestasis along with inflammation, increased ALT, increased SAP. Histo will give you lobular and portal tract inflammation. Examples are chlorpromazine, tricyclic antidepressants, ACE inhibitors, augmentin, and erythromycin. Vascular disorders like peleosis and non-cirrhotic portal hypertension is caused by anabolic steroids, OCPs, and vinyl chloride. vanishing bile duct syndrome. You have a progressive destruction of the biliary tree. This is caused by flucloxacin, chlorpromazine, augmentin, cotrimoxazole.